Ilioinguinal and iliohypogastric nerve blocks, a low-fidelity task trainer. In this video, we will guide you through building a model that demonstrates the technique for performing this procedure. We have no financial conflicts to disclose. By the end of this video, those watching will gain an understanding of who could benefit from these blocks. They will also learn how to identify anatomical landmarks and map nerve pathways, create a simple and effective task trainer, demonstrate how this model will enhance procedural techniques and clinical practice, as well as briefly review nerve block-related complications and best practices. The ilioinguinal or iliohypogastric nerves, tiny but mighty, are frequently at risk during common obstetrical and gynecologic procedures, especially with fan and steel incisions used in C-section birth and lateral trocar placement. Neuropathy of either nerve can result in pain that appears immediately after surgery or that slowly evolves over time. Nerve blocks offer a targeted, minimally invasive solution and potential diagnostic tool for patients suffering from neuropathic abdominal or pelvic pain. This model stands out for its simplicity and affordability, with a total cost of about $20. All components were sourced from materials already available within hospital supply closets, or easily purchased from big box retailers and online stores. It's not only affordable but also highly replicable, making it ideal for widespread educational use across institutions. Now for a quick anatomy review. There are two studies listed below that describe the slight variation in the anatomical course of the two nerves. For the purposes of this task trainer model, we relied on the results of the Whiteside study. First, you will note the umbilicus cephalad and the pubic symphysis caudally. The anterior superior iliac spine, or ASIS, serves as our primary point of reference for mapping the nerve paths. We want to inject the local anesthesia in the plane between the fascia and muscle where the nerve pierces through the facial layer. The ilioinguinal nerve enters the abdominal wall about 3 cm medial and 4 cm inferior to the ASIS. The iliohypogastric nerve enters 2 cm medial and 1 cm inferior to the ASIS. Now, let's get to building. Start by clipping the convoluted foam to fit the cardboard box you have secured. Then place one layer of foam to represent the abdominal wall. Add your cardstock paper to simulate the fascia. The third layer is also made of foam, to simulate the subcutaneous space. Mark the ASIS with a thumbtack and cover the entire setup with cloth to simulate the skin. After securing the cloth skin with tape, you will mark your landmarks that we previously reviewed. Some important teaching points for faculty to review when working with trainees and this model are that the ideal agents for nerve blocks have not been established. However, we prefer to use Marcaine and triamcinolone for our nerve blocks. There may be cumulative effect to repeating nerve blocks, although the optimal number and timing between blocks has not been established. We ideally aim to reassess patients every 2 to 3 weeks after these blocks. You can see the trainee is able to identify the ASIS and insert the needle at the desired injection site. The task trainer recreates this tactile feedback, creating the opportunity to practice popping through the fascia and guiding the learner into the correct tissue plane. Like any procedure, ilioinguinal and iliohypogastric nerve blocks carry potential risks: bleeding, infection, nerve injury, and inadvertent damage to surrounding structures like the bladder or bowel. This task trainer allows trainees to refine their technique in a low-stakes setting, improving needle control and spatial awareness to reduce complications in real patients. During simulation, faculty can also use this time to review management of less common but important complications, such as allergic reactions or transient weakness. In this video, we explored the clinical relevance of iliohypogastric and ilioinguinal nerve blocks, reviewed key anatomical landmarks, and demonstrated simple low-cost model can effectively simulate this procedure. We've highlighted not only how to build the trainer, but how it enhances tactile learning and confidence. As a final takeaway, remember that anatomical landmarks are critical, but they're just the starting point for the best outcomes. Always tailor your injection site based on the patient's specific pain distribution and their surgical history. With practice, precision, and a patient-centered approach, these nerve blocks can become a valuable addition to your clinical toolbox. Thank you so much for watching.